Mark Amirult, fourth year resident here at Wake Forest University School of Medicine. Get started. So objectives today, start with some anatomy and then some technical aspects like how we take the films. And then we'll do some cases. Basic anatomy here. So this is our, our frontal view really. It's like lungs, obviously. We're looking at our right lung here, left lung. Let's see if this doesn't want to cycle through, but it's okay. And then just kind of the basic angles. So we have call these costophrenic angles, so the angle between the diaphragm and really the ribs. We look there for look for pleural effusions and things like that. Cardiophrenic angle between the heart and the diaphragm. Also helpful for pleural effusions, masses, things like that. And then you also look at the airway. So obviously trachea here, right main stem bronchus, left main stem bronchus, carina here. These are hilar vessels, these structures here. And then, you can see, this is a two-dimensional image, so you see everything, even things outside of the chest, really superficial. So you have your breast shadow, right breast shadow, left breast shadow, which try not to be fooled by that when you're interpreting these films. And obviously the osseous structures, so ribs, clavicles, scapula, and then our vertebral bodies. Right. And lateral view, very helpful. Just adding another dimension. You can see the lower lobes really well, kind of something that might have been obscured by the heart. We can see it very well here. On our lateral view, our retrosternal clear space, looking for retrosternal masses, and we get a great view of the spine. And so in terms of the heart borders, show up. I think there's another slide. We'll wait on that. Yeah, and then get a good view of the sternum as well here. All right. This is just a quick blurb. I talked about this. We call this the retrosternal clear space. It's really the anterior mediastinum. And sometimes if this space is obscured, it's dense, kind of looks like this, but it's here. You're concerned about pathology. And typically we would just say, this space is obscured, get a chest CT, which will give us better detail. But when you see that, you think there's a common differential we think about as radiologists, and it's like the 5 Ps. So the thymus lives here. And in a child, could be a normal thymus, but in an adult, there are thymic tumors like a thymoma. Other things here could be thyroid tumor or an enlarged thyroid. Could also be in thoracic aortic pathology. So an enlarged thyroid could obscure this space. Maybe the most common in adults be lymphoma, and then also a teratoma, another kind of tumor that has a typical location here. All right. So we can talk a little bit about the heart, our frontal view. And so, another kind of checklist item we do when we're interpreting chest radiographs is look at our heart borders. And so I'm going to start on the right here. And really, you don't get a great view of the right ventricle on the frontal view, but you have your right atrium here, this border. And if that's obscured, typically things like pneumonia or something are the cause, but it's a border we look for, sign called silhouette sign, which you may learn about a little bit more later in education. Won't talk about that too much today, but and then of course we have our hilar vessels, which what I mean by that is like the pulmonary arteries and the bronchi. Keeps going forward. I have that on the other side. We have our left ventricle here. See a little bit of the left atrium. And then our aortic arch, something we look for commonly. We can also see our superior vena cava, inferior vena cava over here. And here's a kind of a better diagram for showing that. See our right atrium, inferior vena cava, left ventricle, this little bump showing the main pulmonary artery. Sometimes when that's enlarged, you can talk about, enlarged pulmonary artery and diseases associated with that. Lateral view, you can get a good view of the cardiac border as well. Posteriorly, you get the left ventricle, anterior, the right ventricle. You can also get a decent look at the aorta and the IVC. Let's see, oh, it doesn't want to. Well, my diagrams don't want to show up, but something that you can think about later is, and it's usually not necessarily based on the medical record, but there's, the valve positions. See if I can show you that. So just to show you quickly, this is just kind of a nice schematic of showing you. Here's our left ventricle here in yellow, our right ventricle here in a green shade, right atrium in red, and our left atrium in blue. I don't know how those superimpose. Remember, this is 2D. And when we look at the valves, like people have valve replacements, there's kind of a pattern that we see. But just so this is our right ventricle and right atrium. So remember from anatomy, this will be the tricuspid valve. So if you see a, radiodense structure here, it's probably some type of tricuspid valve repair. And then this is more of our right ventricular outflow tract. And what comes out of there, the pulmonary artery. So this would be the location of the pulmonary valve here. And that's typically the most superior valve structure. And going on to the left ventricle outflows. So here, like between the left ventricle and the left atrium, we have our mitral valve. So mitral valve repairs you'll typically see in this location. And then, of course, the left ventricular outflow. Here's your aortic valve, so aortic valve replacements. And a trick sometimes people use is you kind of draw a line from this angle here up to the shoulder. And the aortic valve will typically be above that and the mitral valve below. And also just look at the medical record, of course, if that's available. And then here's our lateral view of the same thing. And so we'll have this is our mitral valve here. And this is the tricuspid valve. A little bit trickier. And then we have our, let's see. This is our aortic valve. And what about our left ventricle? And then we have, this is the pulmonary valve. Again, it's kind of the most superior structure. All right. And so move on to a little bit of technique here. And if you're familiar with, how chest x-rays are obtained, it's either, the patient is kind of sitting, typically, maybe it's a sicker patient, they're in bed, we'll get these AP views. So the x-ray beams are coming in from the front. And so what happens in that case, and you can try to think about this a little bit, but so that would be like an AP view, anteriorly, the beams are coming in and we put our detector plate behind the patient on their back, versus the PA view is just the opposite. Typically in this case, the patient is standing up, they're raising their arms. We put the detector plate on their front chest and the X-ray beam is coming from their back. And so really the kind of the trick here, there's a couple of things you can look at, but one is magnification. So without getting into too much physics, but because the X-ray beam is kind of closer to the heart when you're coming from the front, that's going to make the heart look bigger. So the heart looks bigger generally with two things side by side. That's going to be an AP view. So that's one trick. The other trick is just by the technique, we have patients raise their arm in the PA view, so posterior. You can see the shoulders are raised up here, so we can kind of tell that's a PA view. So we'll skip this. But in terms of quality, PA views are generally better. And you can see the technique here. PA view, X-ray beam going to the patient's back, and they're sort of hugging this detector. And here's our AP technique. Again, typically sicker patients are patients in the hospital that aren't really able to stand up for an X-ray. All right. Lateral view, what information does it add? Basically just gives you a lot more information about location, so we can differentiate lower lobes from middle lobes, upper lobes from lower lobes. Get a look at this retrosternal clear space. We get a lot better look behind the heart, a lot better look at the spine. So it can be very helpful. Decubitus views, much more common in pediatric patients. In adults, rarely will get these. But so I would say here at Wake Forest University, we don't really get these on adults. But as in this case, you can see, you can make pleural effusions much more obvious. So patient is lying sort of on the side of concern, and you can see this fluid layering. And so you can use it for detecting pleural effusions a lot better. You can use it for detecting pneumothoraces a lot better because and like opposite to this fluid, which will kind of go down with gravity, air will go up. But really, it's more of a pediatric use. All right. Then we'll do some cases here. And so again, this is emergency room setting. So this case number 1 is a 55-year-old male here with chest pain after protracted vomiting. And so we have our PA and lateral chest radiographs. And just to show you how I go through it, try to look at everything. I think, of course, your eyes are going to be drawn to this radio density here, these patchy kind of linear radiopacities in the left lower lobe here, as well as that left pleural effusion. So obviously this patient has something going on, but I'll start like looking at the abdomen first. This is our gastric bubble. So gas just kind of layering in the stomach. That's normal here, but I look for the diaphragm. Don't see the diaphragm here that well. So that means, typically there's something of a similar density sort of on top of that, which in chest radiograph is usually a pleural effusion of some kind. And then after that, I kind of go outside in. So then I'll look at the bones, even though that's not really a concern. As a radiologist, we look at everything. So I'll look at the ribs, scapula, shoulder, clavicle. Same thing on the other side. Look at the ribs, look at the spine quickly. When I'm looking at the spine, I notice there's this lucency here up in the neck. And that tells me there's some gas in this guy's in his mediastinum that's tracking up into his neck. You can see it along the aortic shadow here. So he's got pneumomediastinum, which means air in the mediastinum. There can be many different causes, but in the case of someone that's been vomiting a lot, what we worry about is, a person that has ruptured their esophagus from the pressure associated with so much vomiting, called Boerhaave syndrome. And just to finish up here, so we talked about this a little bit with the gas we see, but the right heart border, so right atrium, looks nice. Aortic arch, there's some lucency there, but it looks normal. I don't see an abnormal contour here to suggest there's an aneurysm in the aorta. Don't really see the left heart border very well. So that's what we call a silhouette sign from these opacities here. But I don't see a pneumothorax, so that would be like gas, like a line here. Don't see that. And our lateral view just shows me where is this located? Is this, in the left upper lobe or the lower lobe? I'll look over here. And we also call this spine sign, just because this should be lucent here, kind of like this. So this tells me these opacities are in the left lower lobe. Got some layering fluid. And otherwise, the spine looks okay. And so we'll skip this particular thing. And of course, this person's going to go on and get a chest CT. So when we see this gas, they're going to get a chest CT to see if we can identify a cause. And what we see on the CT, it's all this stuff here, very dark. So that's what air looks like on a CT. So a lot of air in the soft tissues of the neck, between the muscles and the vessels. You see he's got decent sized pleural effusions, both sides, gas. And you can see this is where the esophagus should live. And there's a little hole in it. So, that is very concerning for ruptured esophagus, which we call Boerhaave syndrome. And again, here's more gas in the mediastinum. Does actually have some air here, so he has a little pneumothorax as well. So it's a hydropneumothorax and a quite large pleural effusion on that side. And so this is what we call Boerhaave syndrome. And so new mediastinum, and because he's ruptured his esophagus, you're having material enter your chest and mediastinum, and call that a mediastinitis from an esophageal rupture. And even though we know this guy has an esophageal rupture based on the CT, but we'll have him get an esophagram. And this patient has swallowed contrast. This will be water soluble contrast because we suspect a rupture. We don't want barium contrast to be stuck in his mediastinum. So this water soluble contrast, you see this should be a nice smooth contour like up here. And this is a perforation. So confirm the perforation with a fluoroscopy. Yeah. Just basic review here. So new mediastinum, what is that? Pneumo gas in the mediastinum outside of a lumen, so it's not contained in the esophagus or the trachea. Mediastinitis is just inflammation of the mediastinal tissues. And so other causes, trauma is a common cause. Iatrogenic, that means, it was caused basically by something someone has done. So either through surgery, an endoscopy. Sometimes you can have this from when people are on very high pressures, when they're ventilated, and multiple additional causes here. And it's pretty high mortality when you get acute mediastinitis. So it's something that has to be addressed very quickly and seriously. And our cardiothoracic surgeons are brought on board very quickly. And again, so the findings, you're looking for pneumomediastinum, which we talked about before. And you can see a pneumothorax as well. Just the gas kind of dissects into that pleural space. And these people are going to get CTs, and obviously treatment depends on underlying cause. This patient will go on to be managed by our surgeons, and this will, sometimes they'll put in stents if it's really serious. Sometimes it'll be conservative, so they'll just have the patient not eat for a while. They'll have a gastric tube, and if it's small enough, just with time it'll go away on its own. But so it really depends on the situation for the treatment of that esophageal perforation. Okay, different case. So we'll go through some more inpatient people in the hospital. A lot of our chest x-rays we read are for these lines and tubes, many of these a day. And so we're probably the most common is after someone's intubated, they're checking for their tube position. So that's the first thing that I look for when there are lines present. And so this patient, they have a endotracheal tube. And we'll talk about that in a minute. So maybe think about that for a second. What do you think about the position if you have learned about these at all? They also have this, looks like a feeding tube. We don't see the full course, but it goes over where we expect the esophagus would be, so that's okay. But this tube here, there's like this line here that is kind of a radiopaque marker. So a line that we can see the tip. We look for the carina here. And typically we want this tip to be about 3 to 5 centimeters above. We want the tip to be about here, but it's down here in the right main stem bronchus, just in there. And so this is not in great position. We're going to want, so, we want them to retract this about 5 centimeters. And so you also want to look at the lungs, and this is common when you have a endotracheal tube put into one bronchus selectively, because we're aerating only this lung. And so it's kind of subtle, but you can see over here, you can see this more distal bronchi well, and this is quite dense compared to this side. So this left lower lobe has kind of been, there's no aeration, so it's called atelectasis. So it's kind of collapsed partially. So this atelectasis here, because we're not aerating that side of the lung. And so, yeah, it's atelectasis. And so you see we pull our tube back and just compare here. Again, kind of subtle if you don't read a lot of these, but nicely aerated. This has all this radiodense stuff there. This is just a summary slide. I wouldn't worry too much about it, but some people say 3 to 5 centimeters in adults. Some people will say 4 plus or minus 2. All right. Another line placement case. So this patient had a central line placement for fluid resuscitation. And so that means we want this. Where do we want this? So this is the line for fluid resuscitation they got. Typically, you want that to be in the venous system, or not typically, you want it to be in the venous system. So the goal here is they put it in the internal jugular vein, and where that should project, well, think about, see if we have an anatomy slide here, but it should go through the internal jugular vein into the brachiocephalic vein, into the superior vena cava, and end up here near this catheter. And you might recognize this as a hemodialysis catheter. It's quite large. This comes in through the right internal jugular vein into the SVC with its tip in the right atrium. But this one, this is projecting over this structure, the aorta. So this is actually in the arterial system. And so this is malpositioned central venous catheter that has accidentally been put into probably a carotid artery and ended up in the aorta. So important to recognize this, not the correct position. We're going to have to probably call in vascular surgery to help them take this out. So yeah, this tip is actually in the aorta. And so I mentioned this already, but this is a right central venous catheter, which we see a lot of these here in patients with renal failure. It's a dialysis catheter. And this is in the right atrium. All right, again, just a summary slide, but typically we want these catheters in the superior vena cava or in the right atrium in case of hemodialysis catheters. All right. Next case here. This is more of an ED type case. So patient presents with a history of hypertension, chest pain. And so we kind of go through our search pattern. We'll sort of skip through, but upper abdomen looks okay. The bones, look at those quickly, they look okay. But the thing kind of screaming out here is as we go along our left heart border, this aortic shadow is way too big. So we're very worried about this aorta. And so, up here. So yeah, where's the abnormality? Kind of told you, but aorta is very big, and we think about a big aorta or abnormal looking aorta. We think about acute aortic syndrome. In this particular case, aneurysm or dissection is the main concern in the descending thoracic aorta. So this patient is going to get a CT emergently. I'm kind of skipping through my slides here, but so they got their CT, and you can see this is the level of the arch. This descending aorta, dissection flap, some darker or hypoattenuating materials, what we say on CT. This is clotting blood in a dissection. And you see our dissection flap here, it goes down into the abdomen. So this is a descending thoracic aortic dissection. And things that we talk about, is where this flap goes. You can see in this abdominal artery, it's the celiac artery or the SMA. That's highly stenosed from this dissection because it extends into it. So that could potentially be an issue for the patient. It's something they have to consider in surgery. And so, yeah, so this is a acute aortic syndrome. And so when the pathology of this or the pathophysiology is basically blood, because this patient's hypertension dissects into a layer of the aorta, aortic wall, really. And when, blood enters there, there's tear, and then it can cause disappearance and obviously all of the associated pathology. But typically, hypertension and smoking, big causes. People with connective tissue disorders, which you may learn about, Marfan syndrome, Ehlers-Danlos, multiple additional conditions. And so complications, of course, as we saw here, if you are highly narrowing an artery in the abdomen, you get, ischemia associated with the organs it feeds. Of course, stroke if this goes up into the greater vessels off the arch. But the appearance, we talk about a superior mediastinal widening. And this is kind of a very typical appearance for this descending thoracic aortic aneurysm or dissection. And so, yeah, we'll go very quickly to getting a CTA of the chest. And what do they do for these patients? Of course, you control the really causes blood pressure. And so for this kind, depending on the complications, they may go to surgery because of that narrowing of the abdominal aortic arteries. Sometimes if they're small, you can just manage them medically when it's the descending aorta, which we call this type B. But anytime it involves the ascending part of the aorta, so if we saw, this structure involved, that's very quickly going to go to the operating room and be a surgical treatment with a graft. Alrighty. So this is kind of a subtle case, but this is fairly common as well. So 16-year-old has a history of asthma. They have chest pain. I won't make a guess here. But again, we look at all the structures. So I look at the upper abdomen, quickly look at the ribs, the shoulders, and look okay. The spine looks okay. But then I'm looking at my heart borders, and I see a little line here between the heart and the lungs, and it's a little bit more than I would normally see. And so that's a little bit of gas in the mediastinum. And so this 16-year-old has a tiny bit of pneumo mediastinum, especially you can see it goes along here under the heart. But just finishing my search pattern, I look at the lungs. I don't see anything in the lungs. And in the lateral, same thing. Spine looks good. we confirm that we see a little bit of gas here in the mediastinum. And so this, it's pneumomediastinum, so gas in the mediastinum. And in the 16-year-old with asthma, it's probably just because of the asthma. In this case, not a big deal. Just watch the patient clinically. So yeah, this is just another, it's not necessarily benign. If he's having asthma symptoms, you want to treat those. But in younger patients, we can see this pneumomediastinum in patients that come in with chest pain, and it's because of their small airway disease with asthma. And so we'll talk about this in a second. So we do use dual energy for our chest radiographs here sometimes. And so basically this is especially helpful for looking at the lung. So we're using different energies of X-ray beams to help us see things better. And so in this case, it makes this gas kind of around the heart here much more obvious. So we'll get two sequences with that. This is sort of the lung one, soft tissue view. This is the osseous view, or the bone view, bone window. And you can see the osseous structures very well here. And this is just kind of our regular combined view. I won't get too much into this, but basically what they do is, again, we're using two different energy levels of our X-ray beams. And what you can do is, just use, so low energy beams, the bone is going to absorb that really well, like much more so than the soft tissue. So the bones are much more apparent on a radiograph. Whereas at high energy, it's going to go both through our soft tissues, so our lungs and our muscles and our bone. It's going to go through those both quite well. So there's not going to be as much of a difference. And we can basically use that. So this one, we see the low energy, we see the bones really well. So we can use that as a bone window. And then we can subtract that from our high energy image. So we get a really good view of the lungs without the bones in the way. And so that's why you get the images that look like this. So we've actually subtracted this from this. We get a good view of the soft tissues. And this is basically just a low energy view here where we see the bones really well. All right. And so this is another case patient with dyspnea. And heart looks a little bit big, but I'll just tell you, they have a right-sided corticath, so to administer chemotherapy, looks in good position. The tip is at the junction of our superior vena cava and the right atrium. But otherwise, it looks okay. Same on our lateral view. So we're not really seeing a cause for the patient's chest pain on this chest radiograph. What would be a cause for chest pain? Well, some of the things we've seen before could be just a simple pneumonia, but we don't see anything. And so this, just a normal chest radiograph. Again, we see our gastric bubble here. And so, but the patient is having a high heart rate. They're tachycardic. They're still very short of breath. And important history is they came off of a 12-hour flight and they have some swelling in one of their legs. And so in that case, you're not going to be satisfied with just getting a chest radiograph. It makes you concerned about a pulmonary embolism because, people that are sitting on a plane for a long time are at risk for getting these DVTs in their legs, which can then propagate into their pulmonary arteries in the lungs. And so this is our American College of Radiology. We have these criteria that can help us decide what's an appropriate study to be done for a patient. And so when you suspect a PE, like in this patient, truck driver, concern for PE, sharp pleuritic pain, tachycardia, these are all big signs of pulmonary embolism. You start with a chest radiograph, but if that is unrevealing, you go to your CTA chest. And 9 means this is a very appropriate study to order. And so this is just summarizing that. And so basically, yeah, we don't have to get into this too much, but obviously you want to make sure the patient isn't allergic to contrast whenever you're doing CTs. And if that's just something in the hospital that our staff always does. But we just want to make sure there's good timing of our contrast. And so machines are very smart. You can put a little field of interest here, and then when that lights up with contrast, the CT machine will take the images, and so you see this nicely acquired study. You want to have all the contrast in your pulmonary arteries, because what you're looking for is these filling defects in the pulmonary artery. And so this is a very large PE. We call it a saddle pulmonary embolus. A filling defect, going across to the main pulmonary artery, and then right and left pulmonary arteries. This is the very serious PE, a very large central PE. It's a pulmonary embolism. That's what it looks like on CTA. Again, some of you may have heard of, in the workup of these, more of the clinical signs. Oftentimes tachycardia is the most common sign, but shortness of breath, chest pain, even sometimes coughing up blood. The Wells criteria is a criteria we use to sort of triage patients and how likely they are to have a PE, including things like, do they have cancer? Are they, not moving around? They're bedridden. Do they have calf swelling or tenderness in the calves, history of DVT, things like that. As we talked about before, the chest x-ray is really meant to rule out other causes, to sort of not necessarily exclude a PE, but give other good reasons for the patient's symptoms. And so we don't use these much anymore here because we get a lot of CTAs of the chest, but it is possible to sometimes see these. And so what we call these Westmark and Hampton signs. Wouldn't worry about them too much. I don't find these very often, but see this opacity here. And this lucency here. So sometimes an absence of vessels can indicate a PE. And sometimes you can see actually a pulmonary infarct from an opacity. And those are some secondary signs on chest radiographic PE. And that's what I have for you guys. Feel free to ask any questions you have.
Laila, do you have any question? It's only you. Maybe the time is not right and is it a bit too difficult? Be honest, Laila. Be honest.
Hello, ma'am. Sorry. Yes, ma'am. It's raining in Kathmandu, which is our college located. So I think they're having some internet or like electricity problem there. I'm in my hometown, so I think
Okay.
that's the problem for today's. The
Okay.
level is like beginners levels. Everything is like you go through anatomy and then discuss the cases, and that's like the level is good, ma'am.
Okay. Okay. We can have a talk behind Mark's back. I know it. Okay, we talk later, Laila. Hey, thank you. I'm gonna put this in the YouTube just in case anyone want to see it. So I'm gonna stop now. I will talk to you later. Okay. Thank you. Thank you.